Someone called Fadi Sawires asked, is there a particular formula that you use to get that R number from the number of cases? So if you have the number of cases and you have the date and you have whatever, is there just an easy formula, or is it quite a complicated one? How does it work?
I think as with all these things, you can get a rough estimate fairly quickly, or you can get a slightly more thorough, rigorous estimate with a bit more work. I mean, the basic formula, or the basic idea, is that if the serial interval is, say, about 4 or 5 days, as some studies have shown for COVID, then the ratio of change in cases over that period gives you a rough idea of the reproduction number. So, if it triples over that period, roughly the reproduction number is probably around 3.
And someone else commenting on something earlier in the talk, Tejas Shinde says, similar to Zika, it would have been interesting to hear an example of Salmonella or pneumococci for R, considering their ability to develop resistance. So presumably you do it for bacterial infections as well as viral ones?
Yes, so these are very common ideas across a number of pathogens, of things where there's vaccines in place. These are really kind of important ideas. And then obviously, the potential for resistance or something like seasonal flu that evolves. Obviously, these become more complex characteristics. You might have a reproduction number to this year's strain, people build immunity, and then that changes. So the basic idea is the same, but then those elements of the dots, you have to put a bit more thought into what they actually represent.
And talking of dots, someone else is comparing it to the other model that they've probably heard about. I've certainly heard about the SEIR model. So how do the two kind of work in tandem with each other?
So they slot in very neatly together. So the SEIR model, essentially you have individuals mixing at a given rate. So if you think of those kind of opportunities, transmission probability, that's kind of wired into the SEIR model. If you if it's something people are familiar with, it's the beta term, and then the duration is reflected in the gamma term. And then obviously in the SEIR model, if you have an uncontrolled epidemic, susceptibility declines. So actually you can pull the dots out of that model by looking at the right bit of the equations, if that's something people have gone into more detail with.
And also someone commented that the first case in France was actually now confirmed as 27th of December 2019. So what do we know? Obviously you showed that chart, what we knew at the time, but what do we know as of now as to when the cases first came to France, came to Europe, came to the UK?
Yeah, so there's I know there's been sort of more speculative suggestions of earlier infections. Again, it depends on the reliability, and as you go further back, trying to sort of piece together those sequences. But it is plausible that some of these infections were being exported in December, January, given Wuhan had an outbreak there. And as I mentioned about this super spreading property, it's entirely believable that some of these outbreaks may have been exported and just not sparked outbreaks. We estimated early on that you probably need about 4 or 5 introductions to have a good chance of an outbreak establishing, given these properties.
And finally, there's quite an interesting comment here, I thought, which is about, you talked about the seasonality amongst some of the viruses, like flu, for example, but also don't immune genes and diseases also have oscillating functions within them? And would those timescales be similar, or is the oscillation solely a function of the population?
Yeah, that's great. There's a whole range of these features that interact, and I think untangling the exact contribution of those. I've worked a lot in kind of respiratory infections, and there's quite a lot of debate around the extent to which it's, if you think about the dots, we can measure the reproduction number very easily, but working out, is that a change in susceptibility? Is it a change in virus survivability, sort of the transmission probability? Is it just people behave slightly differently at different points in the year? I think those things are sometimes quite hard to actually extract from the formula. I think even with COVID, we're seeing debate around season effects. And I'm sure there probably are some season effects from one part of the year to the other, but the extent to which it's the virus or the person or our behaviours and environments is very hard to put a clear number on.
Interesting. There's a few more questions that are a bit more sort of asking your opinion more. So Garth Wilkinson asks, has the UK done badly in mortality per capita because it's such a prominent transport hub?
I think there's a whole number of features that have played into both the UK and elsewhere. I think it's the UK's role as a transport hub probably explains why we got a lot of those early introductions. If you look at that curve, why we were seeing so many in February, perhaps relative to other countries in the world. I think in part it's obviously influenced by what control measures went in when. It also influenced by where transmissions happened. That countries that have had a lot of transmission in places like care homes, we know this is an infection that has much higher mortality in older age groups. So I think really a number of these different factors will have played into the differences we see in countries. But obviously, trying to piece together exactly what's had what effects. I mean, the questions around which control measures have been most important in different countries is something we're working hard on. A number of others are, but it's very difficult given that so much happened in such a short space of time.
Actually, I've got a few questions on that, actually, because you'd imagine obviously people are very interested in your opinions of the lockdown and other measures that have been put into us to reduce that transmission rate. So Kai O'Neill is a very basic question. It says, do you think the lockdown is effective at reducing the R rate? And I guess my supplementary question would be, if it is, by how much do you estimate?
Yeah, so I think yes. I guess the specific way of putting it is, I think the measures that have gone in a number of countries have reduced the reproduction number below 1. I mean, we estimated even from changes in behaviour. Colleagues of mine were running surveys post-lockdown, and we saw about 78% drop in behaviour. So that was enough to get the reproduction number below 1, and cases have come down. But then there is that deeper question of what elements of those behaviour change contributed towards that, because we use the word lockdown a lot to describe control measures, but what we've really got is a basket of a whole range of different interventions, from school closures to business closures to work from home to leisure closures, staying at home, all these kind of things. And each one of those will have done something, but actually the precise contributions, I think, are still not entirely clear.
And on those precise contributions, Garth Wilkinson's asked about the Swedish approach, where they sort of didn't didn't impose social distancing measures. I mean, do you have any comment on what they've done?
Yeah, so I mean, Sweden seems to have kept the reproduction number around 1 over a prolonged period of time. So particularly early on, it didn't, unlike many countries where the reproduction number came below 1, they saw a decrease. Sweden, it kind of just slowed to a plateau instead. And I think a number of countries are obviously loosening measures now. So Sweden didn't put in no measures. They put in quite a lot, just not as stringent as other countries. And it may well be that a number of countries converge to a similar level of stringency where, they're not fully open, but they're far more opened up than when lockdown went in. But I think a key difference is going to be, if you've got a reproduction number of 1, what really makes a difference is your current level of infection. That if you've got 1,000, 10,000 infections a day, that's a very different situation going forward to if you've got low level transmission and you've got 10 cases a day and you can keep it at that low level. So I think that will be the difference between countries of the level of infection they're at, even if they've got what seems like a flat epidemic.
Interesting. There's a slightly more politically loaded question here from Dave Colhoun, and if it's the David Colhoun I think it is, that's the UCL pharmacologist who you might know, who says, we locked down on March the 12th. By then it seemed obvious what was coming. No retrospectacles needed. Do you think that SAGE was too timid in recommending lockdown? If so, would you agree that they must bear some of the responsibility for the large number of excess deaths?
So just to answer, we locked down on, does he mean 23rd? No.
Well, he said March 12th, but
okay.
I was what he said. But
I mean, I think certainly the consensus from SPIAM on the 16th was that stringent measures were needed. But I think it's always essentially been a largely kind of political question of the order and the stringency and the implementation you want to put that in. I mean, I think, it's a sort of difficult question to answer. I mean, from a kind of political side of things, it's not just epidemiology. We were, I think, very clear that we had an exponentially growing epidemic and we needed stringent control. But obviously, exactly how that's implemented, things were phased in over time. If things had been put in earlier, we would have seen a different outcome.
There's actually a question that's, I guess, a psychology question, much more than it is an epidemiology question. But William O'Brien asks, which I quite like, does the fact that the rules were relaxed slightly give people the illusion that everything is fine again? And should there be a severe lockdown time with an abrupt finish? So would it work better if it was just very abrupt, tomorrow we're all shut in, next day we can go out? Or do you think these kind of relaxation of measures, or do you think that relaxation of measures is needed because we don't actually know what measures do what?
I think that's a good behavioural question, slightly outside my wheelhouse. I think there is a risk that people think this is all over. I think even in some of the questions I get asked, there seems a sense that this is kind of all done and we're now just going back to normal. And I think ideally we can get to a situation where it can be kept so low and controlled through these targeted measures, the disruption is much less. But I think we know what happens if we go back to a situation where we have exponential growth. That's what's happened in February, March. We're getting reminders from the United States currently if reopening happens too soon. And I think it is going to require quite a lot of trust and people being on board with, as measures are lifted up. If restrictions are lifted on gathering size, those are limits, they're not quotas. And if people do go out and particularly in indoor spaces have large gatherings, it's very likely we will see flare-ups again.
Actually, there are lots of questions about the pandemic, as you can imagine. So Owen Donnelly asks, given the DOTS formula for R, should we be wearing face masks more widely, as in some countries?
Yeah, I think, some of the best evidence I think I've seen comes from some of the groups in Asia, where they've obviously been through. Hong Kong had about 98%, 99% of the country wearing them in public spaces throughout a large portion of the epidemic. And they still had flare-ups in the middle. So I think they made quite a good point that these are probably a very useful measure, but they're not enough on their own to control the epidemic. They still had periods where the reproduction number was 1 or 2. I think that makes sense, given that we've seen a lot of transmission in workplaces and in closed environments, that masks can contribute something, even if they're not enough on their own to control the outbreak. And I think it's going to be the case that there won't be one measure, but I think we have to stack up as many as we can, as effectively as we can. As you said, also just acknowledging that we don't know the exact effects of all these things. And that is the challenge, I think, in communication as well, that you need quite decisive steps and decisive guidance, acknowledging that actually, we don't have a really clear idea of whether masks are going to give us a big reduction in transmission or a far more modest one.
We've actually had a few questions here about the dreaded phrase that came out of those early days of the the government daily briefings, herd immunity. So David Prowse asks, without a vaccine, can distancing and quarantine reduce COVID to a level we can return to normal? Or are we stuck with permanent distancing until mostly we've gained some herd immunity? And similarly, Tina asks, is herd immunity likely to develop? And Denzel Kane says, given an R naught between 2 to 3, what proportion of the population needs to be infected, vaccinated to reach herd immunity?
Yeah, I think for me, herd immunity is essentially what happens if you fail at containment. And I think in those early stages, given the transmission we had, and a number of other countries had, it wasn't entirely clear the extent of reduction we had. We did a lot of work in late January, early February, even just trying to work out if the China lockdown had worked. And I remember when we announced that we thought it had peaked, and we got a lot of abuse from people who thought that there were issues with the data and it was actually still growing. And so I think that is a kind of tough one in terms of where it goes next. But I think my hope is that we can maintain it at low levels with targeted measures. As we've seen in a number of countries where some combination of physical distancing and those kind of other approaches have kept it at lower levels. Because of course, given the reproduction number we've got, even if population structure means that, the herd immunity threshold for an R naught of say 3 is about 67% in a very simple mathematical model. Mm-hmm. So it may be that population structure, in reality, that number is slightly lower, but a lot of the serious surveys that are coming out at the moment, even for the UK, in London, it's in the sort of, I think 10 to 15% range. So it's very far, even if it is a reduced value. So it may play some role in dynamics. I think New York, there's a study out today about 20%. So that may have some impact on the dynamics, but I don't think it's the case that we're really anywhere near that. I think there's a lot, obviously, we need to understand still about immune response and antibodies versus T cells and all this kind of thing. But I think the focus has to be on containment. And unfortunately, we are getting countries now where they've introduced lockdowns. It hasn't fully stopped the outbreak. They're seeing rising transmission. And I think in some of those areas, it may well be the case that accumulation of immunity combined with whatever else can be feasible in terms of control is what slows the epidemic down. But I think that really should never be the primary objective. It's a consequence of being unable to do anything better.
Interesting. So one other thing, quite an interesting question here, which is this idea of obviously science. The science of this is we've kind of, what's the word? We've watched this science evolve in real time as lay people, as people watching the news and reading scientific articles. So how much were you able to refine the COVID-19 models as the new data became available during the pandemic, and how much did outcomes change when you put in some new data and new models, and how has that work kind of changed over the last sort of 6 months?
Yeah, I think that's a good question. I think with any modeling study, I think the key thing to ask is, does the answer to the question you were trying to answer change based on the sort of new data you're getting in? So, for example, early on we used data on kind of severity to estimate what the likely hospital burden might be if, for example, only very light measures are put on, or if you had an uncontrolled epidemic. And obviously now we can refine those hospitalization estimates, but if our early model was saying the NHS would be overwhelmed by 20-fold, and then you refine the model and the NHS is going to be overwhelmed by 15-fold, you've still got a very clear conclusion about that particular route forward. So I think sometimes people focus a lot on the details, but actually it's that overarching question of, do you have a different answer? I think one thing where we have developed a lot more understanding, which hopefully will be helpful, is on settings of transmission. That we now know that certain settings, certain situations seem to be much riskier than others, and hopefully that will enable us to target what we're doing a lot more, because obviously lockdowns are these incredibly blunt tools that are to some extent saying that we don't know enough about transmission to direct at particular risky environments, that everyone's staying home and that's just going to cut all those links in the network. But I think hopefully through local measures and through more refined control measures, we can reduce transmission as much as we can without sort of the wide-scale disruption that's happened already.
That's an interesting point here. I'm sure you've thought of this, but I haven't thought of it. So Nicholas Kalita asks, do your COVID-19 models include reinfection? So the assumption that immunity vanishes over a period shorter than the epidemic duration? Because I know that's been a contentious point, if you can get it twice or if you can't.
Yeah, so there have been, there's been a few reports of these kind of reinfections, some of which I think have just been lingering RNA. So obviously, if you do a PCR test, you're not always detecting live virus. You might be detecting fragments of viral RNA, which I think some of those studies, it might have just been the testing feature. We've looked at some elements of those kind of longer term dynamics. A number of other groups have looked at potential impact of waning immunity. But I think to some extent, the question is, does that change the conclusions of what you do in the short term? That, if you had a scenario where countries are sat back and do nothing, that kind of uncontrolled epidemic shape takes that shape because it peaks because of herd immunity. But you're so far beyond your health capacity that it's kind of irrelevant that you've reached immunity by that point, because your entire health system's overwhelmed and the damage is enormous. And so then if it's questions about sort of prevention against reinfection, if we're trying to suppress infection and keep zero prevalence and sort of the level of antibodies at 5-10% as they are, then whether those persist or not won't have a huge effect on transmission. I think where this will become really important is for vaccines. Yeah. That if we're rolling out vaccines, the difference between the immune response of 6 months or 2 or 3 years, I think there's also just the question of, once you've been exposed, what's the effect of that? So even if a vaccine doesn't protect against reinfection or infection, if it reduces severity, then that's obviously still makes a big difference to the sort of outbreaks we'll be seeing.
And we've had a few people comment on that, for example, that this idea that actually some patients are actually having a really, really bad reaction to the virus. Obviously, you're not a virologist, but do you think there might be more than one illness going on, or some other weird pathology that's happening with disease? Because it seems like your colleagues in the clinical side of things still are not sure what's going on with this thing, and it's doing weird things to people.
Yeah, there does seem to be a whole range of outcomes for this. I mean, obviously, the initial focus was very much on COVID as a respiratory disease and not focus on ventilation and this sort of aspect, but there does seem to be this whole range of potential impacts, some of which are seemingly turning to quite long-term impacts. And obviously that's a really key consideration. I think one of the focuses in a lot of coverage has often been on fatality risk, and I think that's to some extent misleading, given that a lot of the impacts of these do come in other ways. If you end up with long-term health effects, that is a big health impact that needs to be considered, I think, and obviously needs to be studied. And because it's such a new pathogen, unfortunately, the timescale we've had to study these conditions is only as long as the virus has been around.
Somebody commenting here about the dispersion factor K, and how does that influence the herd immunity calculations we were talking about earlier?
Yeah, so the just for people who are not familiar with the dispersion factor is
That's me.
Okay. It's a measure of the variation in reproduction number. So reproduction number is obviously the average, but the variation, you might, some people might infect more or less depending on circumstance or biology or other aspects of behavior. And so the K is just a statistical parameter that measures that. In terms of the herd immunity threshold, there's been a few studies basically making this point about network structure. So the kind of theoretical point is, if you've got a network where a lot of people are highly connected, then because they're more likely to both get infected and spread infection, then if they are exposed early in the epidemic and they generate immunity, then maybe you don't need so many people to get immune because these kind of hubs in the network are immune. But I think a lot hinges on the consistency of behavior, that people aren't like the internet or, some wired network where everyone's got fixed behaviors. So if you have a super spreading event, for example, at a wedding, there aren't a small group of people that go to all the weddings. And so that, having that person immune won't necessarily make a huge difference to the outbreak dynamics. And so I think that's a kind of much deeper, it also just plays into the features of what are predictable aspects of transmission we can prevent. There's often a lot of focus on so-called super spreaders. Who are these people spreading stuff? But actually, if you look at the data, it's far more linked to settings. It's kind of these locations and events. And that's something we can predict. It's very hard to predict what someone's viral load will be before they've got infected, but it is easier to predict, a tight-knit indoor environment with a group of people in poor ventilation in, certain other conditions. And that's something you can act upon.
And talking about those networks, I remember earlier we were talking about multiple entries and multiple connections. So therefore, is the government's, this is a question from Stephen Roderick, who says, is the government's plan to set up quarantine-free travel between COVID-19 trusted companies flawed? Because there are multiple routes for travel between A and B, and therefore, if I'm banned from Belgium, I'll just fly to France and get a train or something.
Yeah, I think the structured network means that it's essentially, if you have those routes open, there is going to be that risk of infection. I think the example of a country that's obviously been quite stringent is New Zealand, and all incoming travellers have a very strict 2 week quarantine. And I think as soon as you deviate from that and you have quarantine-free travel for some people, that does create a risk. Again, it becomes a risk management problem that if you can't get the risk to zero, then it's how effectively you stop those, either stop those infections creating outbreaks or isolate them fast enough or follow them up, or have frequent testing at arrival to make sure that if people are infected, they're detected. But again, each of those steps, potentially will have some potential for uncertainty or kind of reduced effectiveness. And then it's about managing. Again, it's not really an epidemiological question. It's, what's the balance of having closed borders versus having them open, but having some risk that you might get cases appearing?
It's a difficult question. So there's also a question from Keisha Bustamante, who asks, when talking about location tracing, I take it you're not specifically involved, obviously, in the app or any of that, but do you think there will be, or are you seeing a resistance because of privacy invasions and conditions? Because obviously the best thing for an epidemiologist to know is exactly where I've been, my exact location data and everything. But obviously I might be a little bit hesitant sharing that with the government.
Yeah, and I completely get that there is this debate that people want to preserve privacy. And when we did that BBC study, privacy was hugely important to us. And we worked very hard to make sure everyone had consented, and we tried to, where possible, avoid collecting unnecessary data. But equally, if you look at countries in Asia that have done contact tracing very effectively, look at places like Taiwan that had a lot of kind of location-based quarantine, Korea that have had location-based triggers for getting people tested if they've been near an outbreak. We're not implementing what they are. And so I think it's really important to have that debate about the balance of what level of sort of privacy and data we're willing to give up to contribute to having a sort of sustainable public health response. But I think when we talk about testing and tracing being this long-term solution for the UK, I think we do need to acknowledge that we're not doing what the Asian countries have done. and we're implementing it differently. We've got different stringency on people being quarantined, and that will potentially have an effect on what the results are. And again, that's a much bigger debate, but I think it's one that we need to have.
Definitely. So I've probably got time for maybe just 2 more questions. I really like this question, actually. It's from Marco Malone, who asks, what's your experience of the degree of collaboration within the scientific community globally to fight pandemics? Because on the political spectrum, the degree of uncoordination, diversity of action among nations seems incredible. Is it the same in the scientific community?
I think it's been extremely good in the scientific community. I mean, having worked on a number of outbreaks over the years, I think it's been so much faster and more open in terms of sharing. I mean, I remember during the Ebola outbreak, you'd have papers appear 2 years after the outbreak with data that no one knew about at the time. And you just thought this would have been really useful if we'd known that. And, you've got a nice paper in a nice journal, but like, why wasn't that shared?
Yeah.
And it's been, I mean, we've had, throughout this, we've had regular calls with modelling colleagues around the world and epidemiologists and groups and people who have been, for the most part, very generous with sharing data. I think that has been very useful. I mean, certainly a lot of our insights, a lot of our modelling built on these kind of open lineless data sets and things that people were compiling, which were just phenomenally valuable. And the early sequence data, and these efforts to really kind of make it available, I think, have been really important. Obviously, it creates the challenge that media jump on preprint results, and sometimes messages that aren't that rigorous get amplified perhaps quicker than they should be. But I think for the most part, science has done things a lot better. I think there's still a lot of progress to be made, particularly in kind of getting things like code and modeling out there faster. I mean, it's something that we've always worked really hard to try and do, but I think the challenge, it's a sort of wider academic one, is that bluntly, these things aren't rewarded in traditional academic structures. So we don't have development support. It's very hard to get funding for this kind of stuff. I think there's lessons that really need to be learned going forward, because I think the more we can get these things out and shared and scrutinized faster, the better.
Excellent. And just finally, there's a really nice question from Phil Parkinson, who says, is there a mathematical model that you described in The Perfect Bet that is also used in the rules of contagion and current COVID-19 thinking?
So, I mean, Monte Carlo simulations are a crucial part of both what we do, and, like Edward Thorp's book on card counting used that kind of method. And it's this idea that if you've got a process with randomness, trying to study it with pen and paper just becomes unfeasible, essentially. So we have epidemic models where you have an element of randomness in transmission. You have perhaps uncertainty in the distributions. So to be able to use those kind of algorithms to simulate very quickly and get the range of results is often much faster than actually trying to work it out with pen and paper.
Well, fantastic.